Welcome to Seattle Children's Pediatrics Grand Rounds and the 37th Annual Roger Johnson Memorial Pediatric Ophthalmology Lecture. My name is Mimi Cabrera. I'm the Chief of Ophthalmology at Seattle Children's. Please feel free to use the chat box throughout the session. We're going to try to save our questions for the end of each talk. And please keep your video off during the talks just to help with the streaming quality. So I want to show you our program for the day. We're going to start with talks geared towards the general audience, including our pediatrics and ophthalmology colleagues. And following pediatrics grand rounds, ophthalmologists will stay on the call for talks geared towards general ophthalmologists for an hour, and then the last hour geared towards pediatric ophthalmologists. So before we introduce the speaker, I would like to talk to you about who Roger Johnson was and also give you some updates from our division. So Roger Johnson was the chief of ophthalmology at Seattle Children's for 40 years and an incredibly important pillar for the community in Seattle as a general ophthalmologist for even more years. It's estimated that at one point, 1 in 10 residents of Seattle were his patient. He passed away in 2007, and unfortunately, I never had the opportunity to meet him, but I did get to speak to his widow, Angie Corrales, who knew him best, and she's shown in this picture. In Angie's words, Roger lived and breathed Seattle Children's for his entire career. He called his pediatrics patients his kidlets. As Angie described, the love from his heart and soul for his kidlets was obvious, and his patients were enraptured during their visits with him, hardly ever crying and always having fun. Roger worked incredibly hard, seeing on average 60 patients a day, of which typically a quarter were no-charge patients. Angie knows this because she was his clinic manager. Roger never took from Seattle Children's, and every penny he earned over all those years related to this hospital he gave back. I want to thank Angie Corrales for continuing Roger's legacy in sponsoring this lectureship, now in its 37th year. I would venture to say that Roger Johnson would be really pleased to see what Seattle Children's ophthalmology has grown to become today. Of course, this is a pre-pandemic picture, and this makes me very nostalgic. To introduce our faculty, Erin Herlihy is our Fellowship and Education Director and has really helped us develop an excellent and well-known fellowship. Christina Tarsi-Hornock passed the chief torch to me a year ago and fortunately has stayed on with us. She was recently announced to be the first woman editor-in-chief for the Journal of APOS, our flagship national pediatric ophthalmology journal, and we are so proud of her. Laura Huang has both pediatric ophthalmology and uveitis training from the University of Washington and runs our pediatric uveitis service, including a combined rheumatology ophthalmology clinic. Francine Barron does both pediatric ophthalmology and pediatric glaucoma, including glaucoma surgery, and has really been excellent in adopting the newest technologies and managing arguably our most challenging patients. Chris Chambers is a superb pediatric oculoplastics and orbital specialist. Andrew Stacy runs our outstanding multidisciplinary retinoblastoma program. And finally, I'm excited to welcome Debarshi Mustafi, who is a retina specialist and clinician scientist trained at the University of Washington, who specializes in pediatric inherited retinal disease. As for pediatric optometry, we're so fortunate to have Vivian Mann, who is not only a national leader in PEDIG, which stands for Pediatric Eye Disease Investigator Group, but is also running our exciting new pediatric low vision program, as well as our contact lens program. We're also pleased to welcome Milda Banza, as one of our newest providers, who's been wonderful with patients and staff alike, now coming upon 1 year of service. And I'm sure many of you are wondering about Avery Weiss, also a previous hyper-dedicated multi-decade Seattle Children's Chief of Ophthalmology who came after Roger Johnson. Avery is currently Professor Emeritus. Joined by Jim Phillips and John Kelly, Avery runs the Clinical Vision Laboratory named after Roger Johnson, and so Roger's legacy lives on in many ways here. I want to also call out the leadership team for Seattle Children's Ophthalmology. I know this picture makes it look like we are just out to lunch having fun, but let me tell you, this team works really hard. Angie Corrales knows how hard it is to manage a high-functioning ophthalmology clinic. In particular, Lachelle Chavez, our clinic operations manager, has guided us through many a crisis in the past few years. Lachelle has also helped us build an incredible ophthalmic technicians and orthoptics team. Jessica Steele, our orthoptist, has taken a lot of leadership in our division in areas of education and skills maintenance, and all of them ensure that the patient and family experience in ophthalmology is excellent. These are the folks who are the backbone of this team, and we're incredibly lucky to have them. I want to end my introductory remarks with some final updates. At Seattle Children's Ophthalmology, we have a wait list of at least 6 months for pediatric ophthalmologists and have a serious access problem, as many of you know. So starting during the pandemic, we've made our referral criteria much more stringent in order to best accommodate the patients who most need to see us. So we will see patients with known eye disease seen by an eye care provider or with identified pathology based on a primary care provider's exam. Examples include leukocoria, ptosis, epiphora, or strabismus. And we will see particular research study patients as well as high-risk patients for eye disease such as craniosynostosis, Sturge-Weber, or neurofibromatosis type 1. These are just examples. And although we have a 6-month wait list, we will get in patients sooner if it is urgent. And then who we don't see, new patients who are 17 and older should be referred to an adult ophthalmologist or optometrist. And then the rest of the patients on this list should be referred to a community pediatric eye care provider, many of whom are on this call today and are really outstanding. I send my own daughter to a pediatric ophthalmologist in the community, and I have absolute trust. You can find a list of excellent community pediatric eye care providers on our website. I want to mention that these exclusions are for outpatients, and inpatients with new symptoms or urgent need for screening exams, we will take care of. Also, we are willing to make exceptions in specific circumstances, such as transportation or language issues. So if you have any further questions, please feel free to email me. This is my email, mimi.cabrera@seattlechildrens.org. So thank you so much for your time and attention. I would like to turn it over to Christina Tarsi-Hornock for the introduction of our speaker. Christina.
Thank you, Mimi. It gives me great pleasure to introduce Dr. David Guyton today. I'll start off by using a phrase from his own bio that he shared with me, which sums it up. David Guyton is a problem solver, a clinical innovator, an inventor, a teacher, and a communicator. Dr. Guyton studied physics at the University of Mississippi and then went on to study medicine at Harvard, ophthalmology at Johns Hopkins Wilmer Eye Institute. He then did a strabismus fellowship with Dr. Gunther van Noorden at Baylor and then returned to Wilmer, where he has been ever since. Dr. Guyton credits his father, Arthur Guyton, of Guyton's Textbook of Physiology, with instilling in all 10 of his children, all of whom became physicians, the ethos of self-sufficiency and invention. Dr. Guyton built a boat and a house when he was a youth, so it's perhaps no surprise that when he became an ophthalmologist, he invented and designed optical instruments. He is internationally renowned for his contributions to both the fields of ophthalmic optics and clinical strabismus. He invented and built one of the first commercial automated refractors, the potential acuity meter for evaluating potential vision in cataract patients. He pioneered the use of retinal birefringence scanning to screen for strabismus and defocus in children. He has been methodically demystifying optics and refraction for generations of ophthalmology residents for decades through his classic lectures and presentations. And to the UW ophthalmology residents out there, if you've ever learned anything from me from my optics lectures, all credit for that goes to Dr. Guyton. In the world of strabismus, he's given us the exaggerated traction test for evaluating forced ductions in oblique muscles, adjustable surgery techniques for adults and for children. He's provided us with explanations for anesthetic myotoxicity, for the dragged fovea diplopia syndrome. He's given us insights into ocular torsion and dissociated vertical deviations, which you'll hear about later, and has provided a theoretical framework for understanding changes in strabismus over time. He has worked with the American Academy of Ophthalmology, had leadership roles at the National Eye Institute, and he has been president of APOS, the American Association for Pediatric Ophthalmology and Strabismus, and also ARVO, the Association for Research in Vision and Ophthalmology. He has countless named lectures and awards, and notably the Weisenfeld Lecture at ARVO. So I would feel intimidated about introducing somebody with over 320 publications and 18 patents, except that I had the privilege of doing my fellowship with Dr. Guyton. And so what I know of him is an inspiring mentor who loves teaching, whose curiosity and wonder and pure drive to explain how things work and how to fix them when they don't were infectious. Someone who treated everyone with kindness and respect, someone who gave the same careful attention to every single patient in the clinic. This made for some long clinics, but the patients still came from everywhere to see him. So I was scouring my house yesterday to look for photos from Fellowship, which I couldn't find, but I did find something much better, an unpatented Guyton invention. So partway through Fellowship, I sprained my ankle and came in on crutches with orders from my doctor to perform ankle exercises. Dr. Guyton went home to his basement machine shop and came back the next day with this, my own ankle exerciser, which I still have. So for this, Dave, and for teaching me to appreciate Johnny Cash, and for all the strabismus and optics you taught me and all of your fellows, I and all of us will always be grateful. Thank you.
Thanks so much, Christina. That's the nicest introduction I've ever had, I think. I appreciate that. It's so nice to be with you today. I wish I could be there in person, but I got to sleep late this morning, which wasn't such a bad thing. So we have several different, two different topics for the grand rounds this morning. One dealing with Down syndrome and one dealing with how we look at each other and how we should not look at each other. So the title of this talk is Why Do Children with Down Syndrome Accept Bifocals So Readily? I have no financial interests or disclosures to make related in any way to the content of this talk or any of the talks today. Now, once it's known that these children with Down syndrome don't accommodate well, this can be easily detected by a pediatric ophthalmologist or optometrist using what we call dynamic retinoscopy. And also this can be treated with bifocal glasses, often with ready acceptance of glasses and with improved interaction with others. So what are the learning objectives for this particular talk here? First, to promote dynamic retinoscopy for the assessment of accommodation. Secondly, to encourage the prescription of bifocal glasses to most children with Down syndrome. And third, to assess the effectiveness of bifocals by the acceptance of the glasses wear and by school performance. I went to the internet and downloaded these pictures of anonymous children with Down syndrome. See all sorts of varieties and shapes and sizes, but there's a common feature. And there's a common feature here, something that's wrong here. Let's look at some more of them. What's wrong with these pictures of children with Down syndrome? Given the fact that about 80% of children with Down syndrome have some refractive error or eye problem that needs attention, where are the glasses? You don't see them here. Where are the glasses? No glasses. So something's very wrong. You go back to the internet and you can find them. Yes, you can find them here. And you see they're all in glasses and all single vision glasses. More of them, a lot of them, more of them still, but there's still something wrong because all these are single vision glasses. And in my opinion, and with my experience, most of them need bifocal glasses to even focus up close. So there are no bifocals here. In looking at over 100 pictures of anonymous children with Down syndrome on the internet, I found only 4 wearing bifocal glasses. We like to fit them up very high so that the line of the bifocal actually cross splits the pupil. None of these are quite high enough, but that's where we like to put them. That's the same as we use for accommodative esotropia. Now, when I was an ophthalmology resident 48 years ago, I was told that children with Down syndrome are hypersensitive to atropine. And I was told not to use atropine for cycloplegic retinoscopy. It will take weeks for the cycloplegia to wear off. But both of these are wrong. They're not true. The children aren't accommodating anyway. So it's never going to, atropine doesn't make any difference. They weren't accommodating to start with most of these children. 80% of the children with Down syndrome that I've seen over the years accommodate poorly or not at all in the first place. You don't even need atropine for cycloplegic retinoscopy because they're really already basically cycloplegic. They don't accommodate. So how do we assess accommodation objectively? With the same instrument we use to measure children for glasses, a retinoscope. The first retinoscope was a mirror with a peephole in it, a flat mirror with a peephole in it, like this, invented in about the mid-1980s, 1800s. And here is a painting of Abraham Lincoln being examined with a flat mirror retinoscope. The light source is behind his head. See the candle behind his head? That's the light source that's imaged into his eye by tilting that mirror, and the retinoscopic reflex comes back in his pupil and tells the oculist here whether he's focused in front of, behind, or at the position of the retinoscope. Now, when electric light bulbs became available, they were incorporated in the handle of this device, and this is the type of retinoscope we use these days, even more modern ones, to refract patients, adults and children, to get the first, only refraction for children, but the first starting point for adults as well, the process called retinoscopy. So what do we see with the retinoscope? We don't see the retina. It's a misnomer. It should not be called retinoscope. In Europe, it's called a skioscope, shadow viewing of the scope, but it's not that either. We're looking at the pupil. We're looking at the light distribution in the pupil. So retinoscope is a misnomer, but we still have it. Now, the retinoscope produces a band of light that is swept across the pupil. Light's reflected from the retina and is viewed in the pupil. That's where we see the light. We're looking at the plane of the pupil. And the direction of movement of that light in the pupil tells us whether the eye is focused beyond the retinoscope, in front of it, or exactly at it. We have a model, an optical model of the retinoscope off to your right here, and it's producing this horizontal band of light that we sweep back and forth across the pupil, called the intercept. We tilt the retinoscope up or down, we see the light, band of light sweeps back up and down like that. Now let's go back to this. In the top panel, this eye in the top panel is focused beyond the retinoscope, beyond your eye, beyond your eye. And in that situation, when you sweep this band of light up and down across the pupil, you see movement of the red reflex in the pupil in the same direction as the band of light is moving. Just watch this over to your left. Watch this, what we call with movement. Here we go. With movement. The band of light in the pupil is moving in the same direction as the band of light we're sweeping across the pupil. That's called with movement, and it tells us that that eye is focused beyond the retinoscope. Now, if we take another eye in the middle panel and focus it in front of the retinoscope, that's the so-called far point of the eye and the myopic eye, then notice the rays of light switched over, cross over each other in front of the retinoscope, and now the first rays of light that get into the pupil are coming from the other side of the pupil, and it's not surprising then off to the left, we see this type of movement against movement of the reflex compared to how the band of light is moving. And that tells us the patient is focused in front of the retinoscope. When we get the patient's focus by adding lenses to the peephole of the retinoscope, as in the bottom panel, that the patient is focused right at the retinoscope, then when that band of light moves down, all the light gets into the pupil at once, into your retinoscope pupil at once, and you see the light turn on and off. The movement is so fast you can't even tell it's moving. It just flashes on and off. That's the end point of neutralization in retinoscopy that we use in refracting people and in judging the accommodation of little kids with Down syndrome and other kids as well, as we'll see. So how do we assess accommodation objectively in a child? With dynamic retina. That means we watch the retinoscopic reflex while changing the position of the fixation target. So the retinoscopic reflex is regarded as the child switches fixation from a distant target, such as a movie and the monitor of the wall, to a fine detailed near target, a so-called accommodated target that you have to focus on to see it. With proper accommodation, the initial with movement that you would see when the patient is focused behind you will disappear completely and change to neutralization. And that's how you know the child is accommodating properly. Here's an example. We have a distant target just past your ear, now usually a video on a monitor, and then we have a foot switch that cuts the video off right at a certain time. And this is a near target that we hold right beneath the peephole of the retinoscope. We get pretty close to the child, up to 20, 15 inches away. And we ask the child first to look at the distant target past your ear. What will you see then? You'll see the reflex, this band of light sweep to the right, and the red reflex moves in the same direction, strong with movement from the child that's focused beyond where you are. strong with movement. Okay, that indicates the eyes focus beyond the peephole, and that's normal when focusing the distance for a normal person. Now, then you call the child's attention to the near target. Put the distant movie off and call the child's attention to the near target. And if the child can see that and focus on it, what do you expect to see? We expect to see the reflex neutralized, but if you see this still strong with movement, that means the child did not accommodate at all. Still focusing on distance, even though attending to the near target. So no change indicates the eye is still focused on the distance, no accommodation. Okay. Now what if you see partial change, partial less movement of the reflex? So less movement indicates the eye is still focused beyond the peephole, but it's called hypoaccommodation. Now, if you see total neutralization of the reflex though, then you know that's normal. And that's what you're looking for in a normal child, where the band of light is moving to the side and the light in the pupil blinks on and off, doesn't really seem to move at all, just blinks on and off. That's no movement, and that's normal accommodation. So, when neutralization of the with movement is slower and complete, accommodation is subnormal. When there's no change in the retinoscopic reflex, accommodation is totally absent. And this is what we've seen, this no change in about 70 to 80% of our children with Down syndrome. They're not focusing close. They seem to be able to, because occasionally they'll just flash a brief amount of focus at close, but quickly lose it. Many of them don't at all, but occasionally I've seen that flash. So it's not that they can't do it necessarily, but they don't do it. They won't do it. They won't bother doing it. And they see blurred at close all the time. So these children with Down syndrome, in the early 1980s, I began to notice this little or no accommodation in about 80% of the children I was seeing with Down syndrome. 1984, I began prescribing high line bifocal children, splitting the pupil with +3 diopter ads to put their focus up close. So wherever their hands were, they would look down, they would automatically focus up close because they were looking through the bottom part of the glasses. High line placed bifocals. I don't think progressive lenses work as well, and they don't work as well in my book with accommodated viscosity either. So I really do like the high line bifocals to make this work. I was hoping at that point to improve the likely deprivation of amblyopia these children had, because they were, everything they saw close was all blurred. So they were developing good vision. I was hoping to improve the deprivation of amblyopia, but what I found was the results were very gratifying because the children wore the glasses. Previously, they didn't wear glasses well at all, but now they wore these things, indicating to me that they were helping. So we started to study at that time. It continued over 15 years. Our orthoptists and fellows did most of the study. We identified 86 children with Down syndrome who had been prescribed glasses in our practice, 1983 to 2017, a 24-year period. The fellows or orthoptists successfully contacted the parents of 57 of these 86 children with an average follow-up of 51 months, over 4 years. 27 had been prescribed bifocals by me, and 30 had been prescribed single vision glasses by my colleagues who weren't entirely convinced by me that bifocals were worthwhile. They didn't do it. The parents were asked if the child was still wearing the glasses. In other words, what was the compliance with glasses wear? We published our study in 2014 in the Journal of Ankle. Of the 27 Down syndrome patients with bifocals, 89% were still compliant with spectacle wear after more than 4 years. But in the 30 Down syndrome patients, children with single vision glasses, only 50% were compliant with spectacle wear. The difference was highly statistically significant with a p-value of 0.002. Now, not all of the 30 children prescribed single vision glasses had their accommodation assessed. Only 12 of the 30. 5 of those 12 had showed poor accommodation, and 7 had showed good accommodation. But of those 7 children, even those with good accommodation placed in single vision glasses, the compliance was only 43%, 4 years later. So should all children with Down syndrome at least be given a trial with bifocal glasses and properly prescribed? Well, from these documented compliance rates, we would recommend yes. Certainly those children with poor accommodation as assessed with dynamic retinoscopy. And yes, perhaps even those who appear to have good accommodation, although more investigation is needed for those. So these children do need our help and can use our help, and we can indeed help them to see better with bifocal glasses in most of them, using dynamic retinoscopy to assess their accommodation and to know whether or not to prescribe the glasses and maybe to prescribe the glasses anyway. So the learning objectives promote dynamic retinoscopy for assessment of accommodation, encourage the prescription of bifocal glasses for most children with Down syndrome, and to assess the effectiveness of bifocals by the acceptance of glasses wear, because it's hard to assess otherwise with these children, and also by school performance. Thanks very much. This is being recorded. I'll put that up there in case somebody wants to look back and look at references. Thank you. Stop sharing.
Thank you so much, Dr. Guyton, for that first talk. That was really fascinating. Would you like to turn your video on for a brief question and answer session before we move on to our second talk?
I just turned it on. Good.
Great. And if anyone has any questions, feel free to put it in the chat and I can start with a question. This is really interesting because I was always taught that kids with Down syndrome are always going to test kind of generally lower vision than other kids. And it doesn't mean it's anything wrong with them. It's just testing error. And yet we don't necessarily think that way about other kids with developmental delay as much. And I wonder if it's because they really do have bilateral amblyopia that we are kind of under treating. Do you feel like visual acuity assessments seem to be better in kids that you put in bifocals after a while?
Let me first mention some studies I reviewed in the literature regarding best visual acuity in children with Down syndrome, best corrected visual acuity. It's not that bad. It's not quite as good, though, as the normal population. So there does seem to be some decrease in best corrected visual acuity. I was so pleased with the patients wearing bifocals that I followed many of them for many, many years until they probably as long as I kept them in bifocals all along because they liked them so much. Visual acuities, yes, I found the visual was slightly decreased in the general population, but not overly decreased. So I'm not so sure that the amblyopia, deprivation amblyopia that I first thought might be there is really there because they tend to be focused in the distance with whatever glasses they're wearing, if you give them glasses, and that probably is enough to protect them against deprivation amblyopia. Does that help answer your question?
Mm-hmm. Yes, thank you. Any other questions?
I really would encourage people to use dynamic retinoscopy. It's easy to do. You have a retinoscope and you can get one because it's very striking that these children don't accommodate well, and you feel sorry for them because it totally blurs it look as if they're totally 60, 70 years old. Can't accommodate.
Are there other situations that you use dynamic retinoscopy?
I use dynamic retinoscopy in a hyperopic child, a child with farsightedness, because we not want to know when we need to prescribe glasses. Now, if the child's old enough to take visions, if the vision is subnormal, by all means, prescribe in a hyperopic child. But in the young child, if they're 3-4 diopters hyperopic, I will use dynamic retinoscopy to see if they're focusing properly up close. If they are, then I won't prescribe glasses, because I would like to leave them out of glasses, because prescribing glasses, we showed long ago, locks them into that hyperopia. Michael Repka and I wrote a paper when he was a fellow, showing just that the loss of hyperopia that normally occurs in children is thwarted by giving them glasses early. I don't like to give glasses hyperopia unless they're not focusing fully, and I tell that by dynamic retinoscopy, a very useful way to tell that.
Interesting. And then do you prescribe bifocals for Down syndrome patients even if they don't need glasses otherwise, if you find they're not hypoaccommodating?
If they're not hypoaccommodating, that may be 5% of those that I have seen. I rarely see patients, I mostly doing adult surgery these days. And I don't see many kids because I can't be around long enough to follow them. But I did always give them a trial of bifocals, even though they seemed to be accommodating okay. And many times they kept wearing the glasses. And the parents would say, gosh, the kid's doing better in school now. So I was most impressed with that, and I'm hoping to impress that impression of mine on the audience here today.
Interesting. Any other comments or questions? So Vivian Mann posted a comment and question. At PDIG, we are currently conducting a study of accommodative accuracy, stability, and amplitude in amblyopes. What is your impression of bifocals in amblyopia treatment?
I haven't used it unless I find by dynamic retinoscopy the child cannot focus up close. That's what brings me into that. Because if they're, because I will do dynamic retinoscopy and filming with amblyopia when the distance glasses are in place. And that's after they come back. I can't do it at the same time as the cyclophysical refraction. But when they come back, I will do that. And if they are not focusing up close, which is the case in a few of them, then I will add bifocals. So I use the dynamic retinoscopy as a measure of doing that, because I'm convinced that that will improve the treatment of amblyopia as well. And I'm glad that study is being done so we can get some good hard data regarding that.
Okay, well, I don't see any further questions. So thank you so much for that interesting talk. And I'll let you go ahead with your next one.
This is the role of the dominant eye in communicating with others. In other words, which eye should you look at when looking at somebody else? Does it make a difference? It does make a difference, which I hope to convey to you today. Again, I have nothing to disclose that's related in any way to these talks today. What's the clinical practice gap here? Well, effective eye contact with others is learned from infancy, normally resulting in a characteristic pattern of alternating refixation from one eye to the other. If you're looking at somebody else and you shift your fixation to the other eye, that person is not going to like that view, and you won't either, because you don't like to look across each other's faces at each other. That person will shift over and look at that eye on the same side. We call that ipsilateral viewing. Ipsilateral viewing is the preferred way to look at somebody else, the same way you look at yourself in the mirror, same way in a mirror. If I shift back, I expect the other person to shift back, and if they do, I know I've engaged. Because that's the normal way we learn, just from ordinary experience. If you don't have a dominant eye, but let's see what happens in this case. It's not well known that when there's poor vision in one eye, or just a strongly dominant eye, apparent loss of eye contact, or even the appearance of misalignment, can interfere with communication with other people. Recognize these problems, oneself or others, and learn how to follow the other person's lead. That may significantly improve interpersonal interactions with others. So learning objectives are these. Study how you look at yourself in the mirror. Use the post-it note, which I'll tell you about, trick. Now, I must say that I said in that disclosure slide, I was not going to promote any material or product. I don't think a post-it note would be considered a medical device, but I'm going to promote tape in another lecture today, Scotch tape. And maybe if you start using that on patients' glasses, it becomes a medical device. So with that caveat, I do have those things I may talk about, but I'm talking about nothing commercial stuff otherwise. Okay, use a post-it note, which I'll talk about later. Use this to give yourself a strongly dominant eye and see your other eye appear to turn out in the mirror. I'll show you how to do that. And third, respond to the eye movements of others to engage them and maintain effective eye contact. Now, this whole story starts out with this 46-year-old intern who was referred to me about 12 years ago, Forster Business. He had had 6 operations already, all in his left eye, from ages 2 to 44. Left medial rectus muscle had been recessed twice, all in the left eye. Left medial rectus muscle recessed right. Developed consecutive exotropia. The left lateral rectus muscle was recessed twice. He developed a vertical misalignment for some reason in there. The left superior rectus muscle was recessed twice, left intraoblique was weakened once, and the left medial rectus muscle was advanced one, all on the left side. So at age 46, coming to me, he had a small amount of esotropy straight ahead, with exotropy on right gaze of 6 and on left gaze of 3. He saw exotropia, an eye turning out in all gaze positions. Left lateral rectus muscle was tight at the time of surgery, and I did take him to surgery. And I re-recessed the left lateral rectus muscle, where he was bothered so much by. He was an internist, and he said his patients get distracted by my left eye. They're always looking at it, and it must look funny, so I have to have it fixed, because he loses eye contact when they look at his left eye. So, assessed that left lateral rectus, and came back the next year at age 47. A little bit more ET in the distance, XT6 at the right gaze, now ET25 in left gaze, where I had recessed that left lateral rectus muscle, but he still saw his left eye turning out in all these positions. He wanted more left lateral rectus muscle recession. Well, I wasn't going to do that, but I did agree, go to the other eye to make things more symmetrical and recess the right lateral rectus muscle. I did that, right lateral rectus muscle recession, 6 millimeters after adjustment. I adjust all my patients these days. And age 47, 8 months post-op, he came back. Now it was ET10 in the distance, even more esotropy in the distance. ET6 on right gaze, ET20 on left gaze. I evened out a little bit more. He still thought the left eye turned out. And he still wanted more left lateral rectus muscle recession. Here he is. You can tell he's on the Hirschberg test, the position of the corneal light reflex. In his right eye, it's just nasal to the center of the pupil where it should be. In the left eye, it's well out. The eye is turning in. It's displaced outwards, so the eye is turning in. That left eye is turning in. And no wonder people get distracted when they look at his left eye, because they see the esotropia. But what he sees in the mirror is exotropia of the left eye. Now, why does that happen? I refuse to defer the theory. Okay, because I did this, I figured this out, and I sent him a copy of the paper we wrote and never heard from him. Hope he hadn't gone on and had more surgery done. It's exotropia. When you look at yourself in the mirror, the rays of light, diverging rays from your eyes, are reflected by the mirror, still diverging, coming from the images of your eyes, which are equally far behind the mirror as you are standing in front. They're the images of your eyes. Now, if you have a dominant right eye, and look at the right eye in the mirror, the image of your right eye in the mirror, what you see there, you will see both eyes in the mirror looking back at you, mirror looking back at you, and you'll see right along ipsilateral viewing for the right eye, like that. The right eye appears straight. If you shift over, though, to the image of your left eye in the mirror, the eyes in the mirror, the image of your eyes looking back at your left eye, neither of the eyes is looking at your right eye any longer, but you see those eyes from the viewpoint of your dominant eye, if you're strongly dominant, pretty much suppressing the other eye. So you see the other eye, your left eye, in the mirror turned out. And if the eye in the mirror is about 1/3 of a meter beyond where you are, which is usual viewing distance, 30 centimeters or so, then you will see that eye turned out 18 prism diopters, which is about 9 degrees. That's a lot. It looks badly turned out in the mirror if you have a dominant eye. Now, the patient's eye would have had to be turned in about 18 prism diopters, or 9 degrees, for him to see his left eye straight in the mirror. But it wasn't turned in that much. It was turned in about 10 prism diopters. So he still saw it 8 prism diopters turned out. So that's why he saw his eye turned out. He had a strongly dominant eye. This often happens clinically with other people as well. This man had esotropy of 35 prism diopters. The right eye had turned in 35 prism diopters, about 17, 18 degrees. Post-op, after surgery on bilateral and medial rectus muscle recessions, he had exotropy of 5 prism diopters right eye, which isn't really visible. You can't see either eye turned. That looks great. But not to him. To him, he saw gross turning out of the right eye, because he was strongly left eye dominant. The surgery had failed, he said. And he had talked his wife and daughter into saying, it looks terrible as well. Because they were used to looking at it like it was, and now it looked like it turned out compared to how it was. Well, what do you do in those situations? What do you convince him and his wife and his daughter that what he sees in the mirror is wrong? You take a picture, you take out your cell phone, He has permission to take a picture and take a photograph. This is the photograph I took of him right here. And I went over to the mirror and I had him look at the picture of himself and also himself in the mirror right above the picture. And did it look the same? I said, well, he says, no, in the picture it looks fine. But in the mirror, my right eye's turned out. I've got to have it turned back in. It's hard to convince these people that what they see in the mirror is the wrong thing. Now, so if you have no strong eye dominance, and look at yourself in the mirror, you're going to see each eye looking back at you because you develop ipsilateral viewing. No strong eye dominance. When you shift back and forth, have you noticed when you shift back and forth in the mirror, you cannot see your eyes move? You notice that? You just cannot see that they clearly move. To another person shifting, you'll see it. But your eyes don't move because your brain suppresses your vision during that movement. Otherwise, you'd see a big blur of movement. So your brain suppresses the vision and it comes on again when you look at the other eye. Try that. You'll see, you won't see your eyes move in the mirror. If you have strong right eye dominance, though, you'll see the right eye straight here, perfectly straight, but the left eye you will see turned out about that much. That's 18 prism buckets or 9 degrees. Amazing that no one had ever written about that before. Okay, now you can experience this for yourself. You can take a post-it note, and again, I have no financial interest in post-it notes. Post-it note and put it up on the mirror in line with your left eye's view of your left eye. Here it is, so you can't see your left eye because the post-it note blocks it. But your right eye can still see your left eye. Do that. Do that on the break. Later. Okay, now, when you're looking at your right eye in the mirror, all things fine. You've got ipsilateral viewing, that's just good. Perfect. When you look over to look at your left eye in the mirror, and your eyes are perfectly normal, they're straight all the time, perfectly normal. With the left eye, you see your left eye with your right eye, but both eyes in the mirror are looking at your left eye, you see, but your left eye is blocked to your left eye by that post-it note, and so you see with your right eye, you see the left eye turned out how much? About 18 prism buckets. That's darndest thing. And if you get closer to the mirror still coming closer to the left, the post-it note still blocks your left eye. You'll see the right eye turn out more and more and more. It's not really turning out. You're just looking at it from an angle, and it appears turned out very much so. Amazing demonstration. Now, in 2004, Livingstone and Conway wrote this paper about Rembrandt. It was Rembrandt's stereo blind. They got that idea because Rembrandt painted a bunch of self-portraits of himself. And in most all of the self-portraits, one eye was turned out. And we don't know whether it was the right eye or left eye, because we don't know whether he was painting the mirror image of himself or the real image of himself, probably the mirror. And up here in the second one from the top left on the right, you see the right eye appears to be turned out. If that were the mirror image of it, it would be his left eye, but if it was the real image of it, it was the right eye. So we don't know which one that was. But it was consistent in most of the paintings and in his etchings, where he inscribed the marks on an etching block that would be used to print copies. He would put it on the other eye, and in the etchings, the eye that would turn out was the other eye. So they figured that one eye truly turned out, and they wondered whether that he had an exotropia, gave him monocular vision, and wondered whether that let him represent 3D objects more realistically on a flat canvas. If he saw the world as flat, would he represent it more realistically that way with only one eye? Okay, that was interesting. And then along comes Chris Tyler, a good friend of mine, a Smith Keller Reliance student in San Francisco, and writes another paper, this time about Leonardo da Vinci, wondering whether he had strabismus. He did a study of a number of paintings that were thought perhaps to be either self-portraits of da Vinci, of Leonardo da Vinci, or copies of paintings of him by other people, or a couple of sculptures as well, drawings as well. And he fit ellipses to the lid fissures and the circles to the pupils and so forth, and calculated that the average turning out of one eye, which he also saw in the paintings and sculptures and so, calculated the average amount was about 10.3 degrees, which turns out to be 18 prism buckets. So the question arises whether these artists might not have had exotropia after all. Perhaps they simply had a strongly dominant eye. After all, they were each well known in their time, and to our knowledge, there are no historical accounts of their actually having stridulation. So we wrote a paper refuting these things, suggesting a dominant eye, and that was published in Journal of April about a little over 2 years ago, almost 2 years ago, showing how you see the dominant eye, the other eye. So let's leave that. Let's leave those clinical things and talk to now looking at each other and see how we should or should not look at each other. Helen Neal, low vision expert, wrote a book on low vision in 1990, and she said in that book that one should endeavor to look at the dominant eye of others, because failure to do so can appear shifty to others, denoting in our culture a shifty character. Now, I don't know about that last part, but he was a low vision person. Many people with low vision have a stronger dominant eye, and maybe that's where she got this idea. But this is wrong. This is wrong. After all, this begs the question, how would you know which eye is dominant? Most people, you wouldn't. Okay. And it turns out to be wrong anyway, but let's see why. In this case, when you look at yourself in the mirror, and neither eye is strongly dominant, as we talked about before, you see your eyes in the mirror looking back at you, and you have this ipsilateral viewing that I've been talking about. That looks good. The right eye looks straight in the mirror. And then you can switch it. But what happens with the left eye's view? The left eye sees your right eye turned out, right? Somehow, the brain knows to ignore that. It ignores that. 18 prism by prism turned out. And we see just with our right eye from the vantage point of our right eye in the mirror. We ignore that turning out by the left eye. When we shift our eye to the other eye with no strong dominance, we'll establish ipsilateral viewing on that side. And somehow, ipsilateral eye contact, we like that. We see the left eye straight. But we don't see the apparent turning out of the left eye that we would see from the right eye's vantage point. We just don't see it. Somehow we've learned to ignore it. That's how you see yourself in the mirror. Always for ipsilateral viewing, unless you have a strong dominance, then you see one eye down. No strong eye dominance, you'll always see it. No matter which eye you look at, you'll see the eye straight. Strong right eye dominance, you'll see the upper eye, the left eye. Okay. Now let's get rid of the mirror. Let's put another person there instead. We look at this on this side, our right side of our body. We'll look at the left side of the person, on the same side of the patient's eye. If that patient, if the person, patient, whatever, looks back at you, and that same side of your eye, that's like ipsilateral view. You both like that. That's good. But then if you switch to the other side, you won't like that, because people don't like to look across their noses at the other person. They'll make the other person switch. The other person switch, you got ipsilateral view again, and you both like that again. So that's what happens. If you switch, the other person doesn't like that, will switch as well. Switch back, the other person doesn't like that, will switch back as well. So this is how we ordinarily look at each other by switching, and how we know we've established contact. We've engaged the other person by this switching back and forth. The other person doesn't switch. They're thinking about something else. If you look at the nose of another person thinking you're well split between two eyes, looks like you're looking off into space. You've got to switch and establish eye contact this way. Try it during the break with somebody, and you'll see what I mean. That's one of the strong eye contact, strong dominance. Okay. Now, we wrote a terribly tedious paper about this back in 2010. A lot of people involved. It got all in this psychology literature. We had to answer critiques from psychologists, and they go on and on forever. And about 87 critiques before we finally got this published. But it covers all these things. A number of trials showing that, yes, the predominant way that people like to look at each other is ipsilateral viewing, not contralateral viewing. I wouldn't recommend reading it. Just remember what oh, look at this. What about, does it work with a dog? Well, I was playing with my son's dog at his house a few months ago. And the dog seemed to be very intent looking at my face. So I held the dog up, looked from one side of the dog's eye to the other eye, and the dog switched. I couldn't believe it. It was amazing. The dog switched just like a person. I don't think cats will do that. I'm not even trying with a cat. Afraid of cats. But the dog switched. And I've learned some years ago that to autistic children. They're being given puppies these days because they learn how to look in puppies' eyes because they're not threatening like humans are. And I guess puppies act like dogs, like humans. They will switch back and forth. So it's probably a very good thing for an autistic child to have a puppy as a pet. Now, this was an experiment of one. Please, if you have a dog, go try it and let me know by email. Because this is an N of one. In my experiment here, I was amazed to find that dogs do the very same switching that humans do, even though they don't look in mirrors at themselves all the time. So it's something about ipsilateral contact that's not just learned from a mirror, it's learned from looking at other people. Finally, let's look at this clip from a movie, For Whom the Bell Tolls, from the 1950s, starring Ingrid Bergman and Gary Cooper. I know you don't know who those people are, but I do. Some of you do today. Now, let me give you the background of this movie clip. Gary Cooper is an American serving as a mercenary in one of the Spanish Revolutionary Wars. He is on the side of the rebels. They have just blown up a bridge, and the national troops are coming after them to capture them. Probably perhaps kill them. He's been shot and he's died. They've fallen in love while he's been there with the rebels, and he's going to take her back to America when they finish the war and live a good life forever after. And she's so looking forward to that. And he's been shot; he can't go anywhere. She's begging him to let her stay with him and suffer the consequences herself. He's telling her to go. He'll be with her in his mind to go. And they're looking back and forth at each other in each other's arms. And we're going to look at their eye contact and see which one is the real actor or actress and which one is not. Which one is just looking at this one. Let's see if this works. Ready?
We won't be going to America this time, but always I go with you wherever.
Look at her looking back and forth.
Understand? You go now.
Back and look at him again.
No.
He's doing it
No,
right. Go back and look at him again. Watch his eyes.
We won't be going to
No
America this
moving
time,
at all. He's trying to
but
remember
always
his
I
life.
go with you wherever you go. Understand? You go now, Maria.
He's trying to engage
No,
them.
I stay with you, Roberto.
No, Maria.
I
What I do now, I do alone. I couldn't do it if you were here. If you go, then I go too.
Okay. So the learning objectives of this little talk. Study how you look at yourself in the mirror. Use the Post-it note trick to give yourself a strongly dominant eye and see your other eye appear to turn out in the mirror. The closer you get, the more it will turn out, appear to turn out. And then respond to the eye movements of others. Follow their lead. If they shift, you shift. And to engage them. And you'll engage them, they'll engage them back to either each other and maintain effective eye contact. Thanks very much.
Thank you so much, Dr. Guyton. It was really fascinating. We have like 3 minutes if anyone has any questions. I don't see any in the chat box. And if people during the break try this out and have more questions after the break, maybe they can come to you. But I want to thank you for really fascinating talks. This is really, really interesting, very thought-provoking.
Thanks everybody for PEDS. We will see you all next week. Have a good day.